Hello, everyone. My name is Sheila Davis. I'm the CEO of Partners in Health, and so excited to be here today with all of you. This is such an important topic today as we talk about building generational wellness beyond the doctor's office. I think COVID showed us that certainly much of what we need to do for healthcare does not necessarily take place within the four walls of a hospital. So glad that we're having this conversation and taking the time to talk about what it will really take for us to encompass all the things we need to make health a priority for everyone. I wanted to share a little bit, a small vignette, a small story from Partners in Health, where the NGO that I work with, will hopefully to highlight this story. When I was in Rwanda about 3 years ago, I met a young mother who had her child who had been referred to the Pediatric Development Clinic, which is a clinic that was started in the face of saving many children who, now that we had an amazing NICU, these children were surviving when they hadn't survived before, but then became apparent that when they got discharged, they still needed a tremendous amount of help long term. So this woman had been referred to our social support program, and she was given a few rabbits. And when I went to visit her in her home, she had a beautiful home she had built for her 6 children, including the one who was part of our pediatric development clinic, had kind of turned those rabbits, literally, into an enterprise for her small community. She was growing tree tomatoes, plums. She was given the responsibility from her village to care for the pump. She was able to encourage other women to get into enterprise, and she was able to change the whole dynamic of her community. Is that health? I think that's a huge piece of health. And I think an important investment that also has to be part of the healthcare that we deliver. So it's hopefully we can talk about this today with this amazing panelist in front of us. Before we start, we wanted to do a poll to get your thoughts on what is health equity and what it means for you. So everybody hopefully has their phones handy, as we all always do. And you'll see a QR code, and you take a picture of that, and then we're asking you to say in one or two words, what does health equity mean? And while this is happening, I'll take the time to introduce our amazing panelists. First, we have Julie Kim, who is the president of the U.S. Business Unit and U.S. Country Head for Takeda. We have Jay Bhatt, who is the managing director of the Deloitte Center for Health Solutions and Health Equity Institute, also primary care physician. We have Tawana Thomas Johnson, who's the Chief Diversity Officer for the American Cancer Society. And we have Megan Ranney, who is the Deputy Dean of Brown School of Public Health, and as of the end of this week, will be the incoming Dean for Yale School of Public Health. So very excited to have all of them today with us. Oh, it's not working. So while we're waiting for that, I'll ask our panelists to share a little bit of what their health equity means to them. I think in my initial story, accompaniment is a word we use at Partners in Health, coined by our beloved founder, Dr. Paul Farmer, which is basically walking beside someone and meeting them where they are. That woman was met where she was, and in that pediatric development clinic, and then the walking continued beyond to her village and her home, where she then accompanied many, many people. So to me, that is where health equity comes in. I'll ask Julie to share a little bit about your word of health equity.
Sure. Well, I don't know that I can do it in a word.
You can do a few words.
But at Takeda, we talk about health equity being achieved if every single individual can reach their full health and wellness potential, regardless of what their social situation may be. And it's important to us because we've been around for 242 years, and we're founded in 4 key values: integrity, honesty, perseverance, and fairness. And those words all come to play when you think about health equity, and it's represented in not just a moral right, but part of what we do from our business perspective as well.
Thank you. Jay.
Thank you. It is just honored to be here amongst just incredible women that are making an impact every day on this issue. And so thank you for all that you do. And for me, health equity shows up in my clinic as a primary care doctor on the south side of Chicago in terms of meeting people where they're at, just as they've said, and for Deloitte, a fair and just opportunity for everyone to fulfill their human potential for health and well-being. And I would say that what's really moving the needle in the conversation is that it's not just a moral imperative, it's an economic imperative with business solutions. And we released a report last summer that demonstrated the cost of health inequities is $320 billion today and $1 trillion in 2040 if we do nothing different. And it's a crisis, and we've got to act now.
Yeah, Jay, I love that, and I often use your data when I talk about health equity. So when I think about health equity, many of us have probably thought about it through the lens of having a fair and just opportunity to live a healthy life. At the ACS, we like to say that we want everyone to have an opportunity to prevent, find, treat, and survive cancer. But I think the other side of that is also acknowledging that there are systems, right, that have to be modified and in some instances dismantled in order to address the obstacles to health equity, such as poverty, discrimination, and other forms of inequity. So I think I love what we're seeing here: justice, community co-creation, designing for all. That's how I think about health equity.
I love that. So I'm going to add on, both from the healthcare perspective, as an emergency physician, we serve as the safety net for the healthcare system in the United States, the only place 24/7, 365 that you can go to get care, regardless of who you are, where you come from, what sort of insurance you have. In that role, I see the impact of health inequities every day. The folks who walk through my door are very often there because they do not have access to those very basic determinants, both of health care, but also of health. And then when I put on my public health hat, it is exactly what you just said about those larger structural determinants. So to me, health equity is about making sure that our system, both within healthcare itself, but also as a larger society, is set up to enable that equal access to the things that allow us all to be healthy in whatever way we define health. And that's also part of health equity, is recognizing that each of us as individuals or as communities have our own definitions, of course, of physical health, but also of what social and emotional well-being looks like, which we know is such a critical part of health, and making sure that folks have access to those systems to help support them, in addition to those that keep them physically healthy, is to me a critical part of health equity.
Here you can see from the word cloud that we're all very aligned in this room, which is the reason probably why we're all here together. I think our challenge often is how do we take these justice and inclusion access beyond this room? And where do we involve and engage people to think about health equity in a broader way that does include issues such as justice, issues such as systems of decolonization, of so many aspects of the importance of how we're addressing this as a society, as healthcare providers, as business leaders, et cetera. So I'm going to start with a question for you first, Jay, and ask, there's such an overwhelming number of areas when we talk about health equity. We can see from these words it's not a monolithic answer. So because there are so many different areas, how do you approach it, knowing that there's not one simple silver bullet?
At Deloitte's Health Equity Institute, we approach it by looking at three inextricably linked challenges. One, racism and bias within and outside the system. The inequities and that the drivers of health cause in communities, and then the systemic and structural issues within the health system. And the way that we're approaching it, given our work, we know we come humbly to this work because it requires co-creation and walking the journey with our collaborators and listening and understanding together how we make this impact, because it's an ecosystem approach, and that influencing key decision makers to say that health equity is not a side hustle, but it's part of your strategy, it's part of your operations, it's part of how you do business and how you think about your work as an organization. Two, it's bringing fragmented stakeholders together so that we are addressing issues like maternal health, mental health, chronic disease, the drivers of health collectively, and creating place-based change. And 3 is driving health equity innovation, where we're supporting social entrepreneurs, 250 by 2030, people of color and women that don't normally have access to capital or community to make game-changing action on health equity. And we do it through innovative collaborations like Illustrate Change. If you've gone by some of the booths, we're creating illustrations of people with dark skin, medical illustrations that less than 5% of that exists. And then creating data tools to have targeted action in communities, from a maternity care deserts dashboard to a health equity dashboard. And so we're really excited about the journey we're on. And I would say that COVID's illuminated one thing, is that if you have employees as a business, as an organization, you're a health company.
Thanks, Jay. Megan, would love to hear your thoughts and experience in this.
So I'm going to share a very personal story about my own work, and then another example from the institution that I'm joining on July 1st from the Yale School of Public Health. So personally, as some of you know, I spend a lot of my time in the pre-COVID era working on firearm injury as a public health problem. It continues to inform much of my work today. And when I think about health equity there, I think about equity in terms of course, the incredible impact of generations of racism in the built environment, the structural inequities that have set up young black men to have 20 times the risk of dying from a firearm compared to young white men. So part of health equity is addressing that environmental change, which has created communities that are so affected by firearm violence. Part of health equity also is acknowledging the other populations that are disproportionately affected by firearm injury. So young black men are at 20 times the risk of dying from gun homicide. Military and veterans and older white men are at a dramatically higher risk of dying of firearm suicide. And in fact, firearm suicide is the leading cause of gun death in this country. And so an aspect of health equity is also thinking about the fact that rural areas actually have the highest gun death rates in the United States. And so how do we address that and think about creating equity there to make sure that other populations as well can join together in order to reduce the risk of injury and death? So that's a personal example that I've spent very much of my career working on, thinking about the various determinants of health and how to address those in a way that creates space for all populations, addressing both kind of the systemic, structural anti-Black racism, and also addressing many of those other sources of equity, geography, socioeconomic status, education, and so on. Another example from Yale, one of our recent graduates set up a program called Data Haven, which brings together data around drivers of health within the community of New Haven, and then shares it back with the community in order to potentiate change. I think this is a tremendous example of how we address health equity in the real world, because all of us know, again from COVID, we watch those dashboards, many of us. Data has the potential to illuminate stories and to drive action. But many communities have been left out of the ability to both gather, access, and then see their own data. And so this organization, like others across the country, exists in order to enable communities to view what their largest health problems are, have data to go and advocate for the policy change that they need, and then work in conjunction with those of us at Yale as well as others across the larger New Haven and Connecticut system to help create community-driven, community-empowered change. And to me, that's the ultimate measure of health equity, is are we doing the things that the communities actually want and need that make them feel healthier? I may come in and say firearm injury is a problem you should worry about, but if they tell me it's actually food insecurity and food deserts, well, I'd better be working on that. And they're able to illustrate that through the data that they have access to.
And can I add one other angle to this also? So when you look at, for example, what's happening at record speed, let's say, in terms of generative AI, creating data that's going to be used to create further solutions, one of our biggest challenges is when you look at the data that we have available from a clinical trial perspective, it's mostly done on white men. And so a lot of the diseases that we are looking to treat, we don't have the data from a diverse population. And that also creates some of the gaps in understanding that create the inequities. And just to share a quick story, I met with an individual who suffers from Crohn's disease. And she's a young Black woman. And she went through a horrible diagnostic journey because she couldn't find someone who would listen to her and understand the symptoms that she was going through and taking it at face value. She was actually told by one of her physicians that, no, black people don't have this disease. So you don't have this, you're fine. Just go home and gave her told her to take some over-the-counter medicines, right? So this is some of the challenges that we also have, and I think it's another part of filling in some of the data gaps that we have is to make sure that when we're studying new medicines, that we're looking at entire populations, and we have to overcome some of the historical mistrust that exists for very good reasons, but meeting communities where they are, listening to them, figuring out what's the way that they want to participate so that we can have better data sets for the medicines that we develop.
And I'd like to just underscore that point because I think the trust piece is incredibly important. I think, Megan, one of the things that you said about sharing the data back with the community, right? That is so important, and it's often a step that's overlooked when it comes to many of the research projects that we're involved with. I remember very early in my career with ACS, we were doing some work in Memphis, which has unfortunately very, very high breast cancer mortalities, and we sent some of our folks out to a community in Memphis to gather some data around whatever it is we were studying at the time, and the community said, well, what happened to the work that you did 5-6 years ago when you were here? We never heard anything from you again, right? We spent time with you. We invited you into our churches. We invited you into our social civic clubs. We invited you into our homes to meet with our families, and you never came back, right? And so the team had to spend a lot of time undoing the damage that had been done because we had not gone back and shared the data with the community. And from there, the thing to do would have been to co-create, right, solutions for that community. So I just wanted to share that as a real example of when you don't do it, the damage that's done, and then we're just resetting ourselves and having to start from square one all over again.
And then I think infusing blame on the people who aren't
right.
participating or refusing to get vaccinated or join a clinical trial. It becomes this self-fulfilling prophecy in that way. I wanted to as we look at this is a big, huge issue. And it's exciting to see just the fact that on this panel alone, we have a great melding of NGOs, of academic institutions, of companies, and that is what is going to be needed to solve this. So and some people may not know that at some of the organizations, Deloitte, Takeda, ACS, signed the World Economic Forum Zero Health Gaps Pledge earlier this year at Davos, and that, I think, is an exciting step forward for accountability for companies who are stepping up to say, we want to address this. So would love to, maybe Julie, if you can share a little bit about what that pledge is, just for people who are unaware, and then a little bit about where you think where we can have these collaborations to move this important work forward.
Sure. So the one thing that the World Economic Forum does well is it brings people from all over the globe into one location, and it really tries to tackle big, hairy problems, right? Which this is one of those. And so this was a pledge signed by, at the time, 39 companies, but I think we have more companies that have signed on.
It's over 70.
It's over 70 now.
CEO,
It's
at the
fantastic.
CEO level.
Who have all come on board now to work together, as you said, in multi-stakeholder fashion, because it is not something that one sector can solve on their own, but to bring all of these different players to the table and come up with concrete principles and actions that can be taken to move us forward in terms of trying to close and make it zero, the health equity gaps that exist. And so while it's great that 70 CEOs have signed this, it's not necessarily something that everyone can do, but I think what we all can think about is what role can we play? So in your local areas, can you be a convener? Are you a subject matter expert in a particular field? Are you able to fund initiatives? Are you able to provide human capital, people, to participate and do some of the work? And I think that's what it's going to take is number of different organizations from a variety of different walks of life, public, private, et cetera, to figure out how they can contribute and be willing to work across let's say, traditional lines that haven't been crossed, and to collaborate.
I would love your thoughts on that and where you think, pragmatically, how can we be creating this health ecosystem, knowing that companies and organizations are a big part of this, but what are some steps that you think could be taken to help achieve this?
Well, first of all, I'm so thrilled that we're part of the group that has signed the pledge, and it's really been an opportunity for us to take a closer look at how we are advancing health equity from the standpoint of the ACS's mission. So I think, the opportunity, as Julia said, it's around multi-stakeholder engagement, right? So we've got this shared vision around advancing health equity, mitigating health inequities. I think we understand that there is passion and there's commitment and there's a real desire globally to do some work around this space. But at the end of the day, it's what does that mean from an investment standpoint, right? So we need organizations that are really willing to step up to the plate and look at their health equity efforts, I think, through both an internal lens as well as an external lens. And so that's something that we've done at the ACS in terms of our organization, looking at the health and well-being of our employees, of our volunteers that support the mission of the ACS. We have 1.5 million volunteers that support our work. We've looked at how we are educating members of our organization around health equity principles and helping them understand how to apply health equity principles to the work that they're responsible for within our organization. And then, of course, there's the external facing work, right? How are we engaging with cancer patients and their families? How are we engaging with communities around cancer prevention and early detection? So I think, this is a time of listening, learning, and then acting. And what the Zero Health Gaps Pledge has done is really provided a lot of resources for organizations to understand how to do this work and how to do it well. I think, there are lots of CEOs and organizations that want to do the work. We haven't always had the resources and tools to enable the work, and that's something that I think we have now, and that's one of the things that I'm really excited about.
I wanted to add that Julie and Tawana, you've been just tremendous, their organization's tremendous collaborators. The Zero Health Gaps Pledge came through a conversation with the Global Health Equity Network, convened through the World Economic Forum, which has nearly 40 CEO organizations across industries. So the idea and the conversation about convergence, how health equity is showing up just not in health, but in financial services, in consumer, in tech, and where are there synergies. So for example, the idea about accessible banking for people with disabilities. So there are tools that have also come out of that. The Global Health Equity Network is chaired by our global CEO, Joe Yu, the Dean of the Harvard School of Public Health, and the CEO of the American Heart Association, Nancy Brown. So, and Dean Williams at the Harvard School of Public Health, along with Joe Yu and Nancy, have talked about measurement and accountability. So this conversation about accountability at the leadership level and at the board level has really been an important part of that conversation and for the Zero Health Gaps Pledge.
And you all have created some great resources for the integration of health equity at the board level, because I know we've used a lot of those resources.
Yeah, and that's just tremendous, important conversation. The board reflecting the diversity and inclusion of the community and the employees we serve.
We've started to talk about this, but the role of public-private partnerships. Are there concrete examples that each of you may have, or what are the key elements that are important to have as part of that? And the accountability built in the bi-directional way would love to hear whoever wants to jump in first about any examples you have or elements you think are key to encouraging more public-private partnerships.
So I'll say there is no way to achieve health equity without public-private partnerships. So just to be very clear, when we are talking about health equity, whether we are talking about changing those environmental and structural drivers of health, or whether we are talking about actual access to health care, neither of those can be done without both the public and academic and nonprofit sector, but also the private sector. Take food insecurity. We cannot fix food insecurity simply through Medicaid saying we're going to provide vouchers, simply through SNAP, simply through academics saying we're going to do studies looking at providing Meals on Wheels to homebound elderly patients. We need to also have grocery stores to be willing to locate in areas that are currently food deserts. We need companies to think about how do you provide food, make sure that your workforce is adequately fed and nourished. And we need nonprofits as well to step up into that space and to think about how do I provide culturally appropriate, fresh, healthy food to populations that may not otherwise have access. There is no way that we can fix that through a single sector approach. It requires that combination of I need the Medicaid payment system to change so that I can incentivize it, but then I need the access to the healthy food that's culturally appropriate, and then I need the delivery mechanisms. And P.S., it all has to be sustainable, which means we need to have a business plan behind it.
I think just to build on that, at COPE, one of the programs that Partners in Health works at, and Navajo Nation has a prescription food program, and a big part of that was working with the small stores on the refrigeration needed, on building that capacity there. And I think, had there be just one part of the intervention, which I think we're all used to and want silver bullets, had there just been, we're going to just make sure people know how to cook healthy food, and there's stores that are not able to or don't have the ability for supply chain to stock healthy fruits and vegetables, it wouldn't have worked. So I think that comprehensive model, and by listening to those small store owners say, we think it's a great idea, but we can't do it without help, I think that obviously is a key component.
And I think really, again, kind of double clicking on that environmental component to health, that we all think about health equity as about, we need to change the healthcare system. And yes, we do. We, of course, need greater representation of Black men and women as physicians, nurses, social workers, et cetera. Of course, we need to dismantle our historic structural racism within the healthcare system, make it a place that people feel comfortable and safe, knowing that they are going to get great care. But that is the tip of the iceberg in terms of creating health equity. We need that larger kind of systemic and environmental change, which is truly only possible with the private sector.
Yeah, and I think this is really important, this ecosystem approach in the public and private sector collaboration. We released a study this week looking at the way that employers can spark healthy aging, and it requires public-private partnerships. In fact, the national dialogue about life expectancy is one that's pessimistic, and it's very real and very true that we have declining life expectancy, approaching 1997 levels, and the disparities gap being significant. What we offer is a pathway forward for a more hopeful approach if we think about the moral, economic imperative and this collaboration, so that you can get 20 years of health span, not lifespan, which is living with not great health, but 20 years health span, and that not all Americans can live 95% of their life in good health. And that employers have an important role, public-private partnerships have an important role. And partly this work with community health workers that we've been able to team with Partners in Health in is for self-insured employers, for example, community health workers can play an incredibly important role for their employees that are struggling with some chronic conditions. And then we've, our theory of change invested in mental health, where we spurred 16 social entrepreneurs that are working on mental health conditions with collaborators. And then on patient navigation, which is another critical important work that ACS is doing. And so I think it requires that together. And I'll give you one really interesting example around healthcare organizations. 3 healthcare organizations in one jurisdiction, a service area, that said, we're not going to do our community benefit separately. We're going to think about community benefit and the data as intelligence for a community health strategy. And so instead of saying this is what the data says, numerically or quantitatively, let's spend a week with our community and understand what's happening. And so what it turned out was in employment, lack of jobs was a big issue, not graffiti, not transportation, not some of what the other data said. And so collectively, with putting resources in together, the organizations collaborated, worked with public-private partners like employers and corporations, and created an entrepreneurial district, 14 small businesses that then spurred not only economic mobility for a community that was down and out, but also health. And so that's the kind of, I think, collaborative action that can spur really change. And West Side United is on the west side of Chicago. That's got an ambitious plan to cut the life expectancy gap in 50% by the end of the decade. And that requires this kind of approach of looking at our 4 organizational domains of action. Your own house, what you do within your own organization, products and services that you deploy, the community, and then ecosystem, which is a vendor-supplier diversity work. So imagine supporting an entrepreneur from the community to produce socks that then is sold to the hospital, that then buys those socks from a minority women-owned business.
So I'd like to share a similar example of a private-public partnership that's actually underway that we're a part of that we feel really excited about. And some of you all may know that back in 2020, when a lot of organizations were making public commitments to racial equity, Bank of America was one of those organizations and committed $1.5 billion to racial equity initiatives. We had an opportunity to meet with their foundation folks and talk through some opportunities for collaboration. And it was quite interesting because the bank had never invested in health equity before, but as a result of those conversations, we were able to establish what we call the Collaboration for Equitable Health, and that's in partnership not only with Bank of America, ACS, the American Heart Association, American Diabetes Association, and the University of Michigan School of Public Health to advance health equity work at the community level in 11 markets across the country. So we're now in year 2 of that initiative. Year 1 was really about capacity building and standing up the initiative, which, you know, I liken it to bringing 5 families together and sort of planning a wedding, right? Like we had lots of in-laws with perspectives and thoughts about, you know, what it should look like, and so we've learned lots of lessons as a result of the last year. But what's exciting about it is that not only have these 5 organizations come together, but it's a very community-centric model where the work, the solutions, the interventions are being driven by the community in each of those markets. So it's something that, you know, we'll be sharing more about in the coming years, but it really is part of the bank's commitment to addressing health equity for the long term and really building capacity at the community level for the community to engage in solutions to the issues that they've identified as problems for their community. So it's something that we're excited about.
And if
I'm sure if you, yeah, would love to hear your thoughts on that.
Yeah, so I would say a few things. So one, we created a Center for Health Equity and Patient Access. Our director is sitting here in the front row, so you can all ask her questions afterwards on more details. But we did that so that we had a dedicated team of individuals looking at how can we address this holistically across all the different aspects of healthcare that we touch. And there's a variety of different partnerships, whether it's us one-on-one with another organization or in collaboration with a variety of different stakeholders. And this addresses things like the clinical trial diversity that we talked about earlier, or even things that aren't directly tied to our business. So for example, we've done a partnership with Remote Area Medical at RAM, and they put, basically, think of it as pop-up, but they're not temporary, healthcare clinics in healthcare deserts. And so providing funding so they can open more centers, particularly in rural areas that don't have direct access to healthcare. There are other things like working with the government in terms of whether it's at the state level to look at things like workforce development and alternate career paths, particularly for individuals coming from underrepresented communities, because as we were just talking about, creating that economic lifeline does have an impact on fundamentally changing generational wellness for individuals. So trying to hit it from a variety of different areas. But I think, again, for anyone in the room who's trying to think about what they can do, either as an individual or through their organization to have an impact, it's to think about these different aspects of health equity and figure out how you can plug into a broader system. And I think there's so much effort going on across the country that you'll be able to find partners who are willing to work with you.
Yeah, and I think, Tawana, when you were saying about, you know, the in-laws, everybody getting together for the wedding, I do think there is a trend for partnership in a really good way. And I think the pandemic showed us that you can't do these things alone. There has to be kind of a joint effort. And we know that partnerships are challenging, and there's pros and cons, and it often is getting buy-in from your board or your CEO to engage in a partnership, which may be a different way of doing things. Are there other kind of key elements or aspects of partnerships that you all think are critical, or places where people can use as advocacy to encourage partnerships like this because it is doing things differently, as you said, Julie. And I think that change is often challenging and hard, but this, I do think there's a trend in a really a transformational way that I think to build on these and to share these concrete examples are important.
You know, I would say often when we talk about this issue, my sense is that it comes from a deficit mindset when there's really an opportunity for a growth mindset. And so helping collaborators and illustrating through stories of those that with lived experience of the impact it's made on them, that there is value that you can create for people and for business when you lean into health equity. And then it's also the language that we use. I mean, equitable outcomes, I understand it, but that could mean something different for different people. So what's a family sustaining wage mean? What is everyone having the best quality, the highest quality health, or for being able to afford health mean? You know, that ends up striking people different. And I think what Julie said is spot on about, like, you having the conversation with trusted messengers, with meeting people where they're at. So some people might want messages from their faith-based community. Some might want it from their community that they spend time with their friends. Some might want it from their clinical team. And so it's asking those questions and listening and understanding. And I had a patient, a Latina woman, who stopped her medicines after several months because she felt like she culturally had to go through a cleanse. But you don't have to choose between your faith and your doctor or your faith and your care plan. But building trust allows you to have that conversation and understand it.
Go ahead. You go ahead, Tawana.
I was going to say just very quickly, I think one of the things that you have to be cognizant of whenever you're working in partnership is power dynamics, right? And being mindful of ways to mitigate them so that everyone's perspective, everyone's talent, whatever it is they're contributing to the partnership is valued. The other piece that I will say, you know, sort of in this landscape where there are lots of investments happening around health equity initiatives, you know, being mindful of the ways in which we are supporting community partners so that there is benefit and value to them from a financial standpoint to do the work within their communities, because oftentimes, you know, I've seen it in my own organization very early on where we thought we were doing something wonderful and amazing by giving a community organization $2,000. Right? And we would celebrate that as like a really wonderful thing. And I suppose in some ways maybe it was, right? But if we look at that in comparison to the way we fund other initiatives, maybe not so much. So just again, being mindful and bringing an equity lens to the partnership piece is really important.
So from the academic perspective, exactly that. As an academic institution, particularly an Ivy League one, we have a history of going into communities and saying, I'm going to fix things for you, right? And so to me, a big part of partnership is stepping back, having community members who are actual equal partners on whatever work we're doing, having a longitudinal commitment that I am going to keep showing up after whatever project is done, that we are there for the long term. And then being about amplifying the voices of those partners. I mean, and granted, now I'm sitting here on this panel instead of having some of my community partners here, so I acknowledge the irony in my saying this, but amplifying the voices of those partners and making sure that their voices are the ones that are heard. I'll say one person who I think has done an absolutely outstanding job of this is a friend and colleague, Arnie Duncan, who runs an organization called CRED in Chicago, a violence interruption program. Every time he comes and speaks, he brings one of his young men and violence interrupters with him. So that it is about amplifying the exposure, the networking, the opportunity for their voices to be heard rather than his own voice, which I think is a big part of partnership. Isn't it awesome? It's a tremendous group.
Yeah, I was lucky enough to visit Chicago CRED too. Yeah, amazing, amazing work that's being done. And
one of many great violence interruption programs in the in the country, but yeah.
And I think if we think about health beyond the doctor's office, a lot of that is creative writing, it's sharing of stories, it's poetry, and someone could say that isn't a health intervention. But obviously that's a huge piece of what we need to do in pushing healthcare, I think, out of the clinic room and the hospitals, and a lot of that is around creative expression and ways of addressing things. So I think as we are moving beyond narrowly looking at what health equity is, what solutions are, I think looking at examples like Chicago CRED and others is extraordinary. Curious of on the panel, are there other, when we think about concrete, pragmatic ways of addressing this from your organization and how we are engaging with the community. I think we've heard some good examples of ensuring that it's long-term partnerships. It's passing the mic, making sure that voices are there. I think that we are, it is often, I think, a challenge in the sense of then holding ourselves accountable to that. Because I think there's often could be a photo op of, oh, great, we do this in the community, and then 6 months later, the data's never shared, that type of thing. What can we as a global citizen group, how do we hold each other accountable and really changing this dynamic?
Can I say one more thing around kind of the partnership aspect is actually, I think that we have an obligation to measure and evaluate. I think that many of us enter the work around health equity from a sense of moral purpose, integrity, justice, and we create solutions with the very best of intentions because they emotionally make sense to us. I think we have a moral obligation in creating health equity to make sure that we are measuring whether what we are doing actually makes a difference. Because otherwise we are spending money that could be spent somewhere else, and even sometimes potentially worsening outcomes. I'll say I was a Peace Corps volunteer before going to medical school, and my country was littered with pumps that had been put in by well-meaning aid organizations trying to create access to clean water, but no one was taught how to go and fix the pumps. They didn't have access to the right pump parts when those aid organizations left. And that's one of those stories that has stuck with me. If they had gone back and measured, did the people in the community actually have access to clean water? They measured how many pumps they put in. They didn't measure what were the long-term outcomes from that intervention. And then it actually created harm because there were fights over pump parts and blah, blah, blah. You know this story very well from PIH. But I think it's an important reminder to us about that importance, that kind of having that long-term view and the measurement of the outcome.
Yeah, Megan, I would echo that. I mean, this work we often do because it's the right work to do and it's mission oriented. But if we aren't systematically, rigorously thinking about design and measurement and evaluation at that point early on, then we won't have the opportunity to tell the value case and the economic case, but also how this intervention delivers on the outcome. And so you can start with things like quality and safety or other things in your organization that you already do and putting an equity lens on it. And that seems to certainly resonate.
It has to become part of the fabric of how you do what you do, right? And on top of being that moral imperative. And part of the work that our Center on Health Equity has done is created this framework that we're going to be using to hold ourselves accountable and to measure. And it may not be perfect, but that's okay. It's a place to start, and we're going to start collecting the data and seeing where we are making impact in other, and maybe others will adopt it as well. But that is the critical piece, so that it's not just this nice thing to do, because when things get tough, all the nice things always get cut in terms of budget and funding, right? So it has to be critical to the business as well. And sometimes I think there's this, let's say, pulling back from that, because, if you make it about the business, then it's a dirty thing. But unfortunately, you have to make it sustainable, to make it meaningful, to get the accountability, it has to be about all of it.
And I think when we approach things from just the charity lens, as you said, that's the first thing that's cut. And I think, there is a business argument for this in many senses of if people are healthier staying in the community, that's better for the bottom line of every insurance company, every hospital. I think that the onus is on us, I think, to be measuring programs like community health workers, et cetera, pushing that out and being okay to iterate when things don't work. And when the situation changes in a community, what worked 10 years ago may not work anymore. And I think sometimes that feeds into it. As donors and, some up here, I think also looking at donor directed and how much is being mandated to be followed, and there's the balance of measurement, the balance of accountability, but also what are we asking people when we're launching a community program to be measuring? What is the grant compliance? If you, for $2,000, you're asking for 40 hours a week of people to be reporting on that, you lose money. You don't actually. And it's difficult for organizations to turn money away because then they're like, you don't need our help. So I think it's also the onus is on the the donor community, on companies who have the great values in which I think we have great examples today, to also be looking at themselves and how, what are the barriers that are being put in place around reporting and requirements so that we can get money pushed into the community as much as possible, build capacity in that community to be able to measure it, but then also ensuring that we have accountability that makes sense. I'm not sure if for any of you who are, are you internally looking at how you're measuring that or getting feedback from people? Because I do think that has been a big challenge.
Yeah, for us at Deloitte, one of the things that we did was openly look at our data around diversity, equity, and inclusion as an organization. So we produce now a DEI transparency report, which looks at where our people are on their journey in professional growth, for example, or what some of the differences are at various levels of the organization. We're also looking at our data, from algorithms and assets from a perspective of, are we having bias and looking for unintended consequences there. And Heather Nelson, who's my teammate here on health equities here in the audience, talks a lot about health equity by design and human-centered design, and that being critical. And then I would say finally, we haven't explicitly brought up, but health literacy and the language by which people understand and receive information is critically important. And that's, I think we've got to continue to double down on that issue.
For me, I'll say from the measurement perspective, from an academic perspective, one of the big things is around NIH grants. I'll say both the requirements for community-based organizations who want to partner, those federal reporting requirements, and particularly now, for those who are not aware, there's a new reporting rule that just went into effect with the NIH that basically takes away, if you work internationally, any international partner that you have basically has to turn all of their data back over to the US partners. This was passed partly in response to COVID and work that was being done in China, but it is just a tremendous disservice to our international partners and to efforts to create equity in partnerships. Some of these NIH partnership grants outside of the United States have been going on for decades. This is dramatically changing the power structure of our work with our international partners, a huge financial burden on them. If any of you here are involved with NIH or want to comment, their website is open for comment as of the 25th, and it's just one of those things that I think that we have a moral obligation to fight against in terms of the reporting.
So from a measurement and accountability perspective, I'll say very quickly, for us, we've always produced DEI reports. Probably we've done that for at least the last 7 or 8 years. What we're doing differently now is that, one, a lot of the DEI work that we're involved with is now showing up in our annual report, which is shared with all of our donors and external stakeholders that support the work of the ACS. But it's also part of our enterprise metrics, right? And so one of the things that we've done, health equity is foundational to all of the work that we do at ACS across advocacy, patient support, and also discovery. We have now introduced in the last 2 years enterprise metrics around not only DEI, but also health equity. And that's tied to executive compensation, right? So we got to talk about that because it's really important that if we, as an organization want to make this commitment that we're holding our executives accountable to helping us get the work done. And then we're now standing up an ESG strategy, and so of course, health equity and DEI is folded into our ESG work as well.
Just say really quickly, similar for us, we've incorporated all of that into our overall sustainability, and now we have an integrated annual report where we do report out the metrics that we track externally, that we have a larger dashboard that we track internally. But as I mentioned, we are working to figure out how we can better, more concretely measure the health equity efforts in particular. And as I said, we'll learn along the way. I think it's an area that will continue to evolve over the coming years.
I'd love to thank the amazing panelists. I think that there's a lot of commonalities we heard today about synergy, about community, about looking at power and accountability within organizations and beyond. And I'll take the moment to end a little bit based on where I started about accompaniment. And I think we heard great examples of accompaniment here around accompanying companies with different organizations, with NGOs, with a wedding party, with a lot of different things. And I think, again, the late Paul Farmer said for accompaniment, I'll go with you to support you on your journey. Wherever it leads, I'll keep you company. And I think their goal is that we need to be in this together, private, public partnerships, academic organizations, and people who are engaged in all aspects of this. And I think you don't have to be a CEO or a clinician to be engaged in this. It's asking the right questions. I didn't know that about NIH. It's very disturbing about that.
I'll
We're going to
send
be
you the link.
tweeting about that tonight. But I think it really is going to take all of us to make these monumental changes. But I think optimistically, we tackle many challenging things as a community, and so the accountability and communities such as this can be key players in that. So I think illuminating that part of our power is really important. So I'd like to thank my panelists today, and thank you very much.
Thank you.